Okay, so my presentation is on hypothyroidism. Let me move this chat box. So this patient was a 49-year-old female. She was seen at Good Samaritan Health Center of Atlanta. This is a Hispanic patient that is predominantly Spanish speaking, and she was here for a recheck of her thyroid. So she does have a history of hypothyroidism. Her initial diagnosis was at the age of 25. At that time, she had presented with dizziness and weight gain, which is typical for hypothyroidism. But at this visit, she was here for a 6-week follow-up to discuss some of her lab work, because her last TSH was found to be 0.01, and we know that the normal range is 0.4 to 4.0, so it was too low. And she had, so originally when she was diagnosed 25 years ago, she was told that it was due to malnutrition. The hypothyroidism was because of an iodine deficiency, which worldwide is the most common cause of hypothyroidism. Not here in the US because we have iodized salt, which has eliminated that for the most part, but something to keep in mind for foreign patients. She was originally from Central America. And so on her last visit, the levothyroxine had been decreased to 25 micrograms, but on this visit, she denied any side effects from the medication adjustment. So the chart here is kind of what I put together. If you look at the most left-hand column, you can see her levothyroxine was being incrementally decreased by 25 micrograms at a time. Her T4 and T3 levels remained normal, but the TSH was too low at 0.01 on most of her lab draws. Okay, so this is her past medical history. Of course, she has long-term history of hypothyroidism on levothyroxine 25 micrograms, but also her mother passed away at a young age from a heart attack, and so that was kind of a red flag as far as her overall health. She also has hypertension, hyperlipidemia, and she's perimenopausal. There was no family history of other endocrine disorders. But the history was limited because her parents passed at an early age. As far as social history, she is divorced but has a male partner. She has a cat, and she has been making efforts to exercise and make dietary changes. So this is her review of systems. So in the bold underlined text were the positive findings. She did report a 5-pound weight loss, thinning hair, some vaginal dryness, which she was using an over-the-counter lubricant for, and some heat intolerance, and also some trouble initiating sleep. And so with classic hypothyroidism, we would see weight gain and not weight loss like she was presenting here, but also, her lab values are off, and we'll come back to that. So in the highlighted text is what you want to be looking for in the review of systems as it pertains to hypothyroidism. So asking about fatigue, weight gain, brittle nails, do they notice an enlarged tongue or a goiter? Are they having any cardiac changes? Hypothyroidism causes bradycardia, so that's where kind of asking if they're feeling anything cardiac related. And then hypothyroidism also can cause menstrual cycle changes. So is it making their menstrual cycle heavier or irregular? And then one thing we did not ask, which I found out later on through my research, was that patients with hypothyroidism can develop what's called, let me see here. I think we go over that in the next slide, but basically asking if they're having any muscle weakness because they have decreased distal circulation, and the decreased distal circulation leads to like the brittle nails and their cold intolerance and temperature intolerance, that kind of thing. She did have some hot flashes and trouble initiating sleep, which is it could be more related to the perimenopause. So going into the pathophysiology of an underactive thyroid, so it's basically this chart here where it's either going to be the thyroid's fault, or it's going to be up in the brain. So if it's the thyroid's fault, then the thyroid just basically doesn't produce the hormones, and so you'll see the classic low T4 and T3, and the elevated TSH because the brain's trying to compensate. Secondary causes are a lot less common. Those are going to be coming from the brain, so the hypothalamus, which extends into the pituitary and the two lobes. So if it's coming from up there, then if it's coming from the pituitary, you'll see a low TSH. If it's coming from the hypothalamus, then you also see a low TSH. So, and then as far as the presentation of hypothyroidism, it's going to decrease the heart rate, so bradycardia, decrease the blood pressure, and it can lead to lightheadedness, weakness, lethargy, and chills. And if you remember, her initial presenting symptoms when she was initially diagnosed was of dizziness and weight gain. And then here is a TikTok to keep you guys awake, if it works. Okay. Oh, you couldn't hear it? There's a lot of TikToks on hypothyroidism. They're pretty funny. Okay, so this is her physical exam findings. And so again, in the bolded text is the positive findings. So she did have thinning eyebrows and dry hair. And then in the highlighted text is what you would want to look at specifically for hypothyroidism. So looking for any bulging eyeballs, or any lid lag. Lid lag would be tested by asking the patient to follow your finger from top to bottom, looking at their eyebrows, seeing if they're missing 2/3 of their eyebrows, or pre-COVID, asking the patient to stick out their tongue and swallow to visualize any goiters. Oh, and then here's the muscle weakness. That can be tested by asking the patient to stand from a sitting position with their arms crossed across their chest. And that's testing to see if they have proximal upper or lower limb weakness. And looking at their hands, if you see any vitiligo, then that could point to an underlying autoimmune condition for initial diagnosis. And again, the nails would be brittle because of decreased circulation. So she did have a thyroid ultrasound performed, which showed a left lobe nodule. So this is not her actual image, but it's just kind of what it would look like, where you see an arrow that says mass. And so based on the size of the nodule, it was not recommended that she have a biopsy. A thyroid ultrasound is used to make sure that there are not any nodules or tumors that could be causing elevated TSH levels. There is also a different scan called a radioisotope scan that would show if the nodule is the one producing the thyroid hormone, and they call those hot nodules. But hot nodules are almost always non-cancerous, and it's also important to know that thyroid nodules are very common. They occur in over 50% of the population, and the chance of cancer is only about 5%, and even when they are malignant, the outcome is generally favorable. And so we go back to that when we do our education, just reassuring her, because it can be scary to hear that you have a thyroid nodule. So these were the diagnoses and the differentials. So she is being worked up for secondary causes of the hormone imbalances. So problems with her pituitary, or possibly even Graves' disease, which is the opposite. With Graves' disease is hyperthyroidism. Okay. So these are the healthy people goals. So the first one is talking about screening those over 50 years old or those over 35 years old if there's a positive family history. The next two objectives are referencing access to care and education in the patient's native language. So this patient had a middle school education, and English was a second language. And then the next two objectives are reducing adverse effects and preventing emergency room visits, and that's because of the medication adjustments, making sure she understands when to seek care and what is considered emergency, the need for emergency care. And so, and the last one is just because of her comorbidities, hyperlipidemia, hypertension, to engage in physical exercise. Okay. So this is a education for the patient, that they understand that treatment is they need to take the levothyroxine for their lifetime, that it can take 2 to 4 weeks for them to notice improvement in their symptoms, and that they will need to come back to get their blood levels rechecked until the TSH is within a normal range. Also, some education on the nodule, the thyroid nodule, that it is found in 5% of patients that have ultrasound exams, and that they're usually not cancerous, and that they usually grow slowly. So here is her plan. So her plan was to stop the levothyroxine altogether, and she was referred to endocrinology. Her thyroid hormones were drawn again, and the goal of her treatment was to normalize the TSH level. The ultrasound was to be repeated in 12 months to confirm its stability, and no biopsy for the nodule or no radioactive scan was indicated at this time, and she was to follow up again in 6 weeks after seeing the endocrinologist. And so she did go see the endocrinologist, which kept her off the levothyroxine, and then they were going to order some more blood work. They were of more specific antibodies, and I believe she was being worked up for hyperthyroidism. Okay, so the implications for the advanced practicing nurse. So the objective of treatment in hypothyroidism is to have the patient be within the span of 0.4 to 4.0. It's important to keep in mind that even if the numbers are within range, they may not be optimal for the patient if the patient continues to be symptomatic, and that further workup with further lab tests, a complete thyroid lab test panel may be needed to determine if the thyroid is actually functioning as normal. Medication therapy for thyroid disease is permanent. Primary care physicians start patients on replacement hormones such as levothyroxine. Levothyroxine is synthetic T4. It is soaked up by the GI system, which coincides with asking them to take it on an empty stomach. And it takes 6 to 8 weeks of the medication to get the TSH levels to respond. Ordering ultrasound can show if there is a cancerous nodule or if there is an active nodule. Radioactive thyroid scan can be considered if you want to further characterize whether the nodule is causing the imbalance. And then so the most common cause of hypothyroidism is Hashimoto's disease, and the most common cause of hyperthyroidism is Graves' disease. And so this case was particularly interesting to me because it seems like she was transitioning, she was converting, even though hypothyroidism is usually a permanent condition, and most patients require lifelong treatment. It is possible. There have been some cases where patients convert from an underactive to an overactive thyroid, and because it's so rare, a lot of times providers can mistake this for just an improper over replacement of levothyroxine. And the theory is that the conversion happens as a combination of genetics. So maybe her parents lived their full lives, they may have converted at some point, and or environmental factors, sometimes a virus, like if she had contracted COVID, which she had not, that could have triggered the conversion from the blocking antibodies to the stimulating antibodies. And if she is, and we don't know, but if she is confirmed to have converted, the treatment for that is just the opposite, anti-thyroid medication. And that's my references.